that the sites at 7 and 10 are just lacking too much bone. She would need to have grafting done where they take it out of her jaw and blah, blah, blah. And they were like, kind of, I think the oral surgeons kind of like scared them.
Yeah.
And they were like, oh, we were told like we could never get implants unless they like break open my jaw. And I think you had looked at the case, and it seems like with like ridge augmentation these days with allograft, it would be reasonable, but she's got to be out of that growth phase. And, you know, I figure for her, it's probably like, yeah, she's 21, maybe she's 27. She's finally got career and money under her belt. So yeah, like 5-6 year plan out. So, you know, I want these to be in there for quite a while.
Let me kick the tires on a zirconia Maryland.
Yeah, I mean, the other thought too was milling when you milled the zirconia, did you mill it with a well in it?
Yes.
Okay, because yeah, and you'll see the amount that I think I went in.
Yeah, when we take a look at it, we'll measure the distance. When we designed it, it looked rather big on the design, but it's very possible that it wasn't. The trough.
Yeah,
the trough
you'll
wasn't.
look at the knot, the one that I didn't touch, and you'll see it just looks like just like a shallow, like just like a groove. But I took the like, and obviously we don't want to weaken the pontic, but
Right.
I figure it's strong enough that.
Well, it begs the question if the bond to zirconia was weak enough that where it wasn't necessarily lying in the trough, is the MDP containing universal adhesive going to produce the bond strengths that we need for this?
Well, I think what's happening is we're asking it to do a lot of tensile force, right? Like the wire bending, and then we figure the forces on a wire to zirconia are not compressive forces at all.
Right.
It's all tensile. It's all this like the wire's in there, and it's this rotation and this and
yeah.
So like, yeah, I mean, I'm sure from a strictly like up and down crown to tooth, I feel like that makes sense. But I feel like the fact that it's that you're just having this wire kind of on there. So like, yeah, I really embedded it in there. And that feels like, because now I feel like, yes, I can get composite to bond over it, and that's strong. What I can't do is just like rely on some like mound of composite bonding and holding the wire.
Right.
Because then I'm just relying basically on one wall. Like it's all zirconia, 3 walls, a wire in, and then one bonded wall of composite, which is then strong.
Yeah.
So, I don't know. I don't know.
The tensile versus compressive argument is definitely super valid here. So, yeah, let's continue. Let's look at it together. I'm going to be with you on Thursday of next week. I think we have a meeting,
Okay,
so we can.
Yeah, that'll be perfect.
Spend a little time.
I think we scheduled her like 2-ish weeks out, so that should be a good time. Carrie Bryant.
He sent me a message today. He's like, I have company.
Yeah.
I guarantee he just wants to apologize for not making it.
That's fair.
I told him, hey, you're always invited but never expected. So.
Yeah. All right. So
let's dive in. What has been? Have you had any sort of thoughts that have arisen over the week related to TMD and airway?
Yeah, I mean, just reading that one article that you said that would be a good idea to just kind of get that article. So that article's focus was capturing the bite for a splint, and specifically looked like it wanted to talk about using the phonetic bite, which I recall you talking about, and kind of remember coming into an appointment where you and Zach were doing it, you and Regan were doing it. putting the, or sorry, not the phonetic bite, the stick bite, doing the stick bite. It just seems like, capture, and I think just in a general sense of like capturing the bite and knowing, like trusting the process. It just seems like there's so much arbitrary. You just pick a stick that's the size of them going S, and you're like, oh, it looks like a microbrush. So you just shove a microbrush in there, and then you capture the bite, and somehow, and maybe it's just not, the accuracy is not as important as just getting, because I get that it's seeding the condyle, so you're getting this, like, having them kind of say, now I'm going to confuse if it was phonetic, right? Because you're having them say the S, and then you're putting the stick in there, regardless.
Yeah.
But the predictability around capturing that bite, and, that in and of itself takes time. It's an appointment. It's like a complex thing, and it feels like if it's not predictable or it doesn't feel like it's predictable, then like it's got a downstream effect. Like that's the most important step of solving the whatever you're doing, capturing a bite, or in this case, to create a splint, because you want the condyle seated. And that's the whole point behind doing the splint, is we're putting them in a position where the condyles are seated. But
yeah, if I may
yeah,
take your comments, and I'll say, I don't want to say mild confusion, because goodness,
no, yeah,
I
think it is,
I still live there, and hopefully provide some clarity. And I have a saying that I'm going to use in a second that I think will really put to rest a lot of the confusion that complicates this entire arena. But when I did this talk in Portland several years ago, I put up this quote by Niels Bohr: "Anyone who thinks they can talk about quantum mechanics without getting dizzy hasn't yet understood the first word of it." And I think this is TMD.
yeah.
So it's super convoluted. Unlike most things in dentistry, where there's kind of just like a perfect answer, we know what a perfect marginal ridge looks like. That doesn't apply here. And it's because of the complexity and the number of variables that go into what determines this guy here. And you can see my screen, right?
Yeah, I can.
Perfect. So where does that mandible go in three-dimensional space? One of the things that the different occlusal theories will often argue is that of these factors here, the orthopedic factors, the muscles, the nerve, the aesthetics, the teeth, the airway, most occlusal camps put a premium on one of these. Who do we got? Carrie Bryant. Hello, Carrie Bryant, the bowling pin juggling queen.
How you doing?
Good.
Hi, Dr. Bryant.
Your company already leave?
Yes.
Oh, good. Worked out.
Welcome.
Yeah.
Yeah.
Well, I can't see you guys. Can you see?
Can you see my screen?
What's that?
Can you see my screen?
Well, it looks like they're trying to get me in, but oh, wait a minute. There we go. I can hear you, but I can't see you.
So you can't see my. What do you see when you're looking at the screen?
Okay, it looks like you guys are coming up now.
Oh, good.
All right. Can you see the PowerPoint now?
Looks like it's getting ready to come up. I can see a picture of you, but I can't see you. And I can see a J for Jason.
Oh, that's good.
Oh, there we go.
We're almost there.
Yeah, I can see you now. Yeah, now I can see Now I can see it. Anyone who thinks they can talk about quantum mechanics
without getting dizzy hasn't yet understood the first word of it.
Yeah, Niels Bohr.
We were just drawing the analogy, let's say the analogy,
Yeah.
the parallel here, that TMD is rather convoluted. And
That reminds me of Woody Allen. He said, "I'm not afraid to die. I just don't want to be there when it happens."
He was like Yogi Berra, many one-liners.
Yeah.
So we were talking, as you came on, we were talking about this slide here, and where does that mandible live in three-dimensional space? And the argument amongst all of the occlusal, I don't want to say the occlusal theories, but the the different camps that deal with occlusion and their thoughts of where the condyle sits. One of the things that I remember hearing from somebody, I don't remember who it was because it wasn't one of the major guys, he was saying how we have all of these factors, the orthopedic factors, the muscles, the nerves, the aesthetics, the teeth, and the airway. And most of the occlusal camps will put a premium on one or a few of these, but few really take into consideration all of them. So
Yeah.
orthopedic factor being where, Carrie would, I think that's where you would hang your hat, that the joint position is the king. And I don't disagree. But I think for the purposes of sharing the complexities of TMD with Jason, that it's driven by many different things. And one of the, I would say one of the most confusing parts of any young dentist's journey in this is how to know whether the jaw is in the right position or not. Whether you're doing bimanual manipulation, or you're doing a Lucia jig or a leaf gauge, or you're just capturing MIP, you're trying to equilibrate. When do you know that you've captured that endpoint? And that's a confusing question. And one of the things I learned from Stephen Olmos is it's not a perfect position. There are many right answers that satisfy all of these requirements. And that was the point I really wanted to drive home first as I was kind of looking over the slides, that there are a series of positions in three-dimensional space that satisfy these requirements enough that the patient's quote-unquote stable, versus it being a very defined point in three-dimensional space. And at Carrie's talk, he talked about that patient that had the, 17 millimeter acrylic splint that was the right spot for her. She probably just needed to be opened a lot because it optimized her airway, and the muscles and the nerves were happy as a result of that. And I have no doubt she was probably fine at 14 and 22. It's a range. It's not, he just happened to land on the perfect spot that satisfied her requirements. So super high level thought. When we are treating TMD patients and really any sort of full mouth rehabilitation, whether it's dentures or not, keep in mind that there's no perfect answer, there's acceptable answers.
Yeah, I would say that orthopedic includes all of these. It's the sum of all of them. So I don't really disagree with anything you're saying. I think in centric relation, you can get a pinpoint repeatable position, but that doesn't mean that that's the only acceptable place.
So Carrie, if you say a pinpoint position, that's a condylar position, what would your answer be for the vertical position of the mandible? In other words, the vertical dimension of occlusion. Is there also a pinpoint position for that, or is there also a range dependent upon the freeway space and the anterior envelope of function? Are they connected?
Well, I think because the joint rotates without translating, I think that you can have different vertical dimensions that are still acceptable.
Yeah, and that would definitely make sense.
Is there a go-to, Dr. Brian, is there a go-to thickness of the, for instance, a splint, let's say? Do you have just kind of I make them 3 millimeters thick and then I adjust from there?
Well, I usually do. I think once you get beyond, I don't know what the millimeters are, but I think once you get beyond 10 or 15 millimeters, in order to stay open, you have to translate the condyle down the eminence. Yeah. So I try to keep it around, 5 to 7 millimeters. and then make the bite as even as you can. And it seems to allow everything on here, allows the muscles and the nerves relax. The teeth still don't get overloaded. And I'm guessing the airway is probably in an acceptable position too. Although I think vertical, from what Piper said, when you open an airway vertically instead of horizontally, you don't really do much to open the airway. Is that true, Nick? That vertical opening doesn't do much? Although I think maybe in the last class I went to, once you get beyond, I think that lady said once she gets beyond 8 millimeters, she can breathe better.
Yeah, there was an article. While we're there, let's take a look at it. So John Comissi is a dentist, I believe in the Maryland area, and he did a study in the Academy of General Dentistry talking about the vertical component of. So this is it right here. The vertical dimension in dental sleep medicine oral appliance therapy. So he, what he felt was through the use of the pharyngometer that there was an impact vertically, but farther forward wasn't better. And the old George gauge approach, which was have the patient pull as far forward as they can, and then your treatment position is 70% of that maximum protrusion. I don't know if you've ever done that, Carrie, but you can imagine what kind of stress that puts on the retrodiscal tissue of the joint. And if I just do that myself, I can feel the stress inside the joint. So as time has gone on, the pharyngometer, which is what I would consider the gold standard objective determining factor for the optimal three-dimensional position of the mandible. Let me restate that because it's super important. The pharyngometer is the only tool that will tell you the collapsibility of the airway at different vertical and horizontal positions of the jaw. And what we found, not we, but what dentists who use the pharyngometer have found, is that the vertical opening plus some combination of protrusion, there's a sweet spot, and it's different in everybody. And it has to do with the fact that when you protrude forward, there's a point at which the airway starts to collapse. So more is not better with protrusion. Likewise, the vertical opening doesn't necessarily result in pure management and prevention of collapsibility of the airway. So there's a combination. But this is the first article that really studied kind of it broke the two down. And the result of the paper, and I'm happy to share it with you if you want, is they both matter. There's a sweet spot. And we've done a lot of this, Ray and I. I would say the sweet spot for most people is edge to edge and open by 4 millimeters from MIP, 4 to 6 millimeters. That's the average. Well, that's not that far forward. Oh, by the way, that's a very comfortable position for the joint, and it's the position that results in the least amount of collapsibility of the airway. And I keep saying collapsibility.
What was it? I lost you for a minute. You said the horizontal opening is edge to edge. What was the vertical? I missed that.
Yeah, 4 to 6 millimeters from MIP.
And that's horizontally?
That would be vertically.
Yeah, I mean, that makes sense to me, although I've heard guys say that if you open somebody vertically, you actually lose some of the airway. And that never made sense to me.
Well, I remember you and I having this conversation, and you had shared some really high-level stuff from Piper. What he didn't have in his papers and his observation that you had shared with me was a combination of protrusion plus opening. He was saying that vertical opening in centric relation can close the airway. In other words, you're staying in that hinge access point, but from a airway perspective, if you keep it there because the airway, the jaw's on an arc, you're absolutely going to close the airway just based on the arc's trajectory. there's obviously a distalizing vector as the jaw opens until you get translation, and then you pull forward. And that's what I think was missing in his. I don't know if it was an article you had shared or a PowerPoint slide you had shared, but he made a pretty massive conclusion that vertical affects the airway. Well, he's right in centric relation, but the moment you start to translate, that whole thing changes. And
Yeah.
I think you had shared with me once that just the medial pterygoid's tonicity can affect the airway. So a patient who has a medial pterygoid that's in spasm, that will have a significant negative influence on the airway, which is just another factor that's likely to contribute to whether an airway stays patent or not.
The other thing that I would be concerned about is a thing called osteochondritis dissecans. I don't know if you're familiar with that term, but
I am
from you. Yeah, you discussed it a little bit during the lecture on Wednesday.
yeah, and when you have a broad area touching a broad area, you don't worry about the bone. But if you bring that condyle down, and now it's a point touching a point, you run the risk of causing the bone to deteriorate if you do it for a long period of time. And I don't know what the total answer is to that, but I do see patients that have that. It's instead of a broad area hitting a broad area, you get a point touching a point. And that's what happens if you bring the condyle down for a long period of time, which is why you probably don't want to wear the dental implant any longer than you have to. So obviously take it out in the morning and don't wear it.
Osteochondritis dissecans. Yes, that's definitely a good one.
Yeah.
One of
It's
the
been
not to kind of deviate from that, but I think that would be good to go over once we start looking at some images of the joint and look maybe at some of your cases in greater detail, Carrie. Carrie, have you ever heard of I don't know if it was a study where they did some tattoos. They made dots on the mucosa on both the upper and lower, and then they did a full mouth rehabilitation where they opened the patient's vertical, and over time they measured the distance between the tattoos and the mucosa, and what they found was patients they came back to their normal or neutral vertical dimension. So that was a concept that said, like, when you open people, whether they're in a splint, orthotic, or full mouth rehabilitation, if you over open them, they will restore things back to normal through generalized intrusion of the teeth.
Yeah, Dawson always said that. I agree with that 100%.
Yeah. When you see these neuromuscular cases, it's always interesting to see how much they open. And one of the reasons why I have such a hard time with the whole neuromuscular world is nature has a very defined endpoint, and nobody in nature has teeth that look like that. So why are we creating that? And it's because they're listening to the muscles, and they find the point at which the muscles are happiest. But that doesn't mean that over time they're not going to have the propensity to go back to normal. So yeah, I guess it was Dawson who had talked about that, and it's an interesting concept, and I think it's one that says, look, the body's going to get us back to normal, or have a propensity to get back to that point. And
yeah, the resting length of the muscle,
correct,
will bring the teeth back to where they were. So you can't open anybody's bite permanently.
Yeah, no, it's a great concept, and thank you for bringing the muscle length. I had forgotten that's probably the predetermining factor that drives whether or not somebody could stay open or not, because that's probably a genetically predetermined physiologic parameter. So yeah, let's come back to the PowerPoint here. There were a couple other slides that I thought were relevant. Gary, you weren't on the call last time, but we talked about how many times centric relation has been redefined in the glossary of prosthodontic terms. And here was their first one. The most protruded relation of the mandible to the maxilla when the condyles are in the most posterior, unstrained position of the glenoid fossa. Fast forward to today, the maxillomandibular relationship when the condyles are positioned in the most anterior and superior position within the glenoid fossa against the slopes, the distal slopes of the articular eminences, completely independent of tooth contact. Do you have any sort of, you've imaged lots of joints, do you feel that the current definition is the most accurate?
That whose is?
The current definition?
Well, I know I actually spoke to Dawson personally before he died, and he said that the definition of centric relation that he had since the 1960s was most superior, most medial, condyle and disc properly aligned, and lateral pterygoid shuts off. So if you use a, electromyography, what would it be? I always get it confused, either the superior or inferior band of the lateral pterygoid won't be active. So it allows it to rest. I assume that would be the inferior, because the superior lobe of the lateral pterygoid allows the disc to get into place, and the inferior attaches to the condyle.
Right.
So it would be the inferior that shuts off. The condyle and disc are properly aligned, and you have most superior, most medial. He never said anything about most anterior.
I think he said, he didn't say anterior, but he said, I can hear him saying this because I've heard him talk many times, up against the eminentia. So seated, but it's as anterior as possible, and it rests up against the articular eminence, which, whether you're saying as far anterior as possible within the glenoid fossa, or as he defined it, up against eminentia, I think is saying the same thing. So you had just said something about the medial pole, or not the medial pole, you said it's the most medial position.
Yeah.
And I think this is a great concept to maybe spend some time on, the medial versus lateral pole of the disc, or the condyle. When you say he thought it was the most medial position, my brain thinks, well, if you bring this medial pole this way, then the contralateral condyle is going to go lateral. So
Looks like connected.
What did he mean by that?
Well, to me, what he meant was just that you can't bring the condyle they're both at the most medial position. You can't bring them either one of them any more medially and superiorly. But then again, you have soft tissue in between, so it's not a bone-to-bone position.
Yeah. Is it just because the medial portion of the condyle is, at least in this image, it's sort of favored? So if you're going to bring the jaw symmetrically forward, am I like looking at this, because it's not these things are not perfect spheres. So you're going to bring that condyle up and forward. The first thing that's going to touch is the medial side of the condyle, and that's going to rest in the fossa. That's sort of what I'm understanding it as.
Yeah, that you can't bring it any higher, and you can't bring it any more medially.
Yeah.
But when the lateral pterygoid fires off, you can bring it. In fact, the only way you can move your jaw to the left is if the condyle comes down. Although I guess that may not necessarily affect the lateral movement of it. But you have to be able to bring the condyle down the eminence on the opposite side. So if you want to move your jaw to the left, you have to be able to bring that condyle on the right side down and forward.
Okay.
And that's why one of the most common things you find when somebody has a TMJ problem, one of the most common findings is that the lateral pterygoid is tender to palpation because it's being overworked. Does that make sense to you guys?
The lateral pterygoid or the lateral capsule?
Well, I would, what I had been taught was it was the whole lateral pterygoid area is tender to palpation because it's, if you have an interference that moves your mandible to the left, the only way it can move to the left is if the right lateral pterygoid fires, because you can't do it with just gravity. It's not like it's going to fall like something falling off a table. You have to fire off the right lateral pterygoid in order to move the mandible to the left. Because the condyle can't move more medially. It has to come, in order to move to the left, it's got to come down the eminence and then move to the left.
Yeah, that makes sense. While we're on this image here, I think this is a pretty good time to talk about capsulitis. So this capsule, which contains the synovial fluid within the disc space, is a ligament. And is it a ligament or tendon? I think it's a tendon. So you can get inflammation of this ligament or tendon, and we call that capsulitis. Do you see a lot of that, Carrie, or do you kind of just throw that under the whole thing is in dysfunction and that's just one of the symptoms of it?
No, I see it a lot. I wouldn't say that, I palpate the, the posterior, the middle, and the anterior of the capsule. I push fairly hard, and a lot of people can have a TMJ problem without tenderness. But on the other hand, a lot of people do have tenderness there, either in the middle or the posterior. They call it retrodiscitis, which is inflammation of the posterior part of the capsule.
Do you separate out retrodiscitis, which would be inflammation of the joint space itself, separate from the capsule itself? Because I think capsulitis is I think there's a specific medical term, capsulitis of the TMJ joint, which is a separate diagnosis from inflammation inside the joint. Do you segregate those two, or are they just one and the same?
I have people open their mouth and then I palpate in behind, and some people are tender back there. As far as what you just said, I don't always separate that out. What did you say, from the capsule, from the posterior part of it?
Well, typically when I see capsulitis, I just palpate without them open.
Yeah.
And they'll be tender there, as opposed to what you said, when they open and that condyle comes down and forward, then you have access to kind of go behind it and access this, this area. This is a two-dimensional image, but picturing we're going behind this image, so we're accessing that retrodiscal space, would be a different diagnosis.
Yes.
Yeah.
Yeah, so I have capsulitis and I have retrodiscitis, two separate diagnoses.
Great. Yeah, that was my question. What I don't know is what causes capsulitis. Retrodiscal tissue inflammation, I totally understand. But why would we get inflammation of the capsule separate from that? Is it from lateral movement?
I think it's just a location of where the inflammation is. You can either have it directly pretty much on top of the condyle, or you can have it in behind, or you can have both.
Gotcha.
That's why I don't really use an NTI very often, because the NTI allows the muscles to relax and the condyle to seat right up in there. And that can be very tender, especially if it's a recent trauma. somebody falls on their chin. I've had dentists tell me that they, this kid fell on his chin and I used an NTI and it didn't really seem to help them. Well, I wouldn't expect it to help them because it's going to allow the muscles to relax and the condyle to seat. And if it's seating up into inflamed tissue,
Yeah, that makes sense.
It would be very normal for it to hurt.
Yeah, I think the the takeaway message with the NTI, if I'm hearing you correctly, if we can somehow through our diagnostic process come up with a diagnosis to segregate out myofascial pain disorder, which is a muscle diagnosis, versus intracapsular condition that's the result of acute trauma, then obviously the NTI or really any anterior deprogrammer, because at the end of the day, that's all the NTI is. It's just an anterior deprogrammer that's low profile and easy for the patients to wear and comfortable. But what tool do we have in our toolbox to segregate out whether there is retrodiscal tissue inflammation? I can think of a couple to segregate that out. And in the absence of that, and we can palpate a muscle, we feel not a trigger point, but we feel a tight muscle band that elicits pain upon palpation. Those are the patients where the NTI appliance is likely to shine. So yeah, any anterior deprogrammer when there is confirmation of inflammation inside the joint is not a good idea. As a matter of fact, the mandibular advancement device often will shine there because you're pulling the condyle a little bit down and forward, which can give the disc and the retrodiscal tissue some time to breathe. But what would be two tools that we could use to determine whether there's inflammation in the joint? You said one, so palpation of the posterior compartment upon opening and translation. And the other would be, what's that?
I was going to say perhaps auriculotemporal nerve block with mepivacaine. Just inject it right into the joint capsule.
Yeah.
And see if the pain goes away.
I like
then it. You pretty much got a diagnosis that the problem is in the joint. And if it doesn't go away, then you've got either referred pain or you didn't do the block correctly.
What about load testing? So putting a cotton roll in between the front teeth and then having them try to clench on their back teeth to seat the condyle.
Yeah, that sounds like a good idea. Although I had bad experiences with load testing really when I was first learning this stuff, and I suppose that would not be a bad idea. I just don't do it as much. Actually, I take that back. I do it. I do it in 3 increments: gentle loading, and moderate, and then heavy loading. And if people have discomfort in light loading, then I definitely stop. And I am more suspicious of the joint itself. But there are false negatives with the load testing, so I'm a little wary of it.
Tell me more. That's really what I was hoping to get some upgrade knowledge about. What's happening when we get the false negatives?
I'm sorry, I should have said false negative. Yeah, you load the joint and they say it's fine, but it's really not.
Is that likely because they're just still sitting on the disc, which is non-innervated, so they're not actually compressing the inflamed tissue?
Yeah, I'm actually not totally sure why it's negative. I guess I should investigate that more. But when it hurts when you load it, I consider that positive. When it doesn't hurt when I load it, I don't always consider it negative. I'm a little wary of the joint loading, but that's what Dawson used to base his whole diagnosis on.
Right.
And that's one thing where Piper strongly disagrees with him. It's one of the 2 things I mentioned at the course was that Piper found that he can load people and it doesn't hurt them, but yet they still have some major issues in the joint. And so what he did to replace joint loading is imaging. So that's where CAT scans and MRIs came in. He does a CAT scan and MRI on every single patient that's referred to him.
This is Piper?
Yeah. I mean, he's retired now, so he doesn't do it. But before he retired, he imaged over 20,000 joints, which is a fancy way of saying he imaged over 10,000 people.
Well, that's a pretty large takeaway for me, you know, because I very much of my understanding of the joint comes from Dawson, and that would make a lot of sense. The imaging of the joint, and when we're saying imaging, we're looking for signs of inflammation. You know, so on a CAT scan, we're looking for osteophytic changes or bird beaking or loss of the cortication of the head of the condyle, things like that.
So hard tissue for the CAT scan is like, oh yeah, it's pretty much all we can.
Now I suppose a good Piper protege, I should be doing MRIs on everybody, but I don't. I only do them on about 20% of the patients that come in.
Well, one might have to remember that Piper was getting the worst of the worst. So he probably had to do everybody. I think you're kind of like the entry level for these complicated TMD patients, and he's getting the people that people like you who are very well trained can't fix, and he needs the MRI.
The 20% of the 20%, essentially.
Yeah, exactly.
Yeah, it's like.
Plus, I think Piper was more likely to be sued, so he really protected himself. I don't know how many times he was sued. Knock on wood, in 46 years, I've never been sued. And every day that goes by, I think what's probably going to happen.
Well, that's probably why you're not sued, because you're worried. So you're crossing your T's, dotting your I's, and covering up your tracks as you walk through the snow. Well,
I try to under-promise and over-deliver. I try to play down anything I do, dentures or TMJ treatment. I try to make sure that I can't promise anything. And what I find is that, I'm going to say 90%. The way I adjust my splints, I'm going to say over 90% of my patients get a benefit from it. It might even be more than that. But
well, while we're on that topic, I think this is a good slide for us to have a conversation about, as you said during your lecture, dots in the back, lines in the front, but more than just what we're seeing with the articulating paper, what's happening to the muscles as a result of this endpoint of what we call a properly dialed in occlusion?
Well, you can test it yourself if you're, if you have a class 1 occlusion, and probably people even that don't, if you bite on your back teeth, you can feel your temples bulge. Mm. And then if you bite on your front teeth, you don't notice your temples bulge. So what that means to me is that about two and a half of your closing muscles shut off. I don't know which ones are still on. I never learned that, but you could just try it, bite hard on your back teeth. So what happens when you bite on your front teeth, you don't have as much force. First of all, your back teeth aren't really touching, or if they are touching, they shouldn't be. And those muscles that shut off prevent you from doing damage. It prevents you from breaking teeth or knocking them loose or moving them to a new position. Excuse me, that's what mutually protected occlusion means to me.
Yeah, it makes
sense. Now, I've actually started adjusting my splints 2 different ways. What Piper taught was if you really have a lot of damage in your joint, you ironically, should do a lower splint where you hit on all your back teeth and not on your front teeth, and you have group function. Basically, what you have is one tooth in your mouth. You go from 8 back teeth to one plastic tooth, and when you go side to side, you're hitting on your back teeth. I have another member up in Canada, Dr. Obey, who doesn't believe in that. He thinks the canines are by far the most important. You should hit on your canines when you bring your teeth together. You should not hit on your back teeth at all. So he takes the back teeth out of occlusion by about 0.2 of a millimeter. And he does hitting on your canines with anterior guidance on at least 2 front teeth. And ironically, I've had patients that didn't seem to get better when I used the Piper technique. So I switched over to the Obey technique, didn't charge the patient any extra. And most of those patients, all of a sudden they come back a couple weeks later and say, I don't know what you did last time, but it really helped a lot. So now I have 2 ways of adjusting splints. And I still haven't totally figured that out, but.
So can I summarize? So this is 2 different orthotic or splint occlusal designs. So you're not talking about the teeth, you're just talking about the splint?
Well, I'm talking about how the splint hits on the upper teeth. And it's basically, the Piper technique is a Gelb appliance. And the Obey technique is a kind of a Pete Dawson anterior guidance technique. And I've used both of them. Usually I start with most people that come into the office have damage in their joints. So I start off with a Gelb Piper technique. And after a few months, if it doesn't seem to be working, switch over to the, I would say the Dawson anterior guidance technique and take the back teeth out of occlusion, but just by a little bit, 0.2. I try to go for 0.2 of a millimeter. So when they clench, they're hitting mostly on their canines and maybe a little bit on their back teeth. And so what that means to me is the person where the Gelb technique works, it's mostly damage in the joint that's the issue. People that do well with the anterior guidance technique, clenching, I believe, is more of the issue. And the canines, if you're not hitting on your back teeth, you can't really clench that well.
But it seems like you're kind of, breaking it up into a muscle and a joint kind of position. Yeah.
Now, Dr. Obey up in Montreal, he uses the anterior guidance technique on everybody, and he swears that he has good luck with it. Everybody, not everybody, but a high percentage. I'm going to guess 95 to 98%. And he's a great guy. He's a fellow colleague in the Piper Study Club, and I've just picked his brain. And he's really a really nice guy and a really intelligent guy.
Is he somebody that we could get on one of these calls at some point? Are you that close to him?
Yeah, better than that. He has a 27-hour. I was the first person in the country to take his 27-hour course. And he's got a lot of, I think I might have told you about it a few months ago, but it's 27 hours for $1,250. It's amazing. Now, for me, it was supposedly review, but it was a fantastic review, and I still learned. I learned this technique that I didn't really learn from Piper.
Did you have to pay the tariff?
Actually, he let everybody in the study club take the course for free if they wanted
Oh, wow. That's nice.
to. I didn't have to pay anything, but even if I did, it was I mean, where can you get 27 hours for $1,250? So I would definitely recommend him if you want to learn more. I mean, I think I can show you guys a lot about TMJ stuff, but to have it organized, I probably can't organize it as well as this guy does. He's got different categories. And
do you have access to that course still?
I do, and I could show you guys the course. I don't know. You probably couldn't get credits unless you paid for it.
No, and that's, I mean.
But if you just wanted to look at it, I would feel bad that I was kind of going behind his back.
Yeah, I know. There's that part, but
at the same time, if one or two or three people wanted to look at it, I wouldn't have a problem with it.
Yeah, I'd have no problem paying for it. The amount of time and effort that goes into clinicians that put stuff like that together, that's pennies compared to, that's half of a splint.
Yeah.
So, there was a couple other things I wanted to go over before we call it here, and we kind of just went over it. And this is, this comes from Dawson, group function. What's happening, destructive over time. This is talking about teeth, but group function from a treatment position in the orthotic. When you talk about group function, I like thinking of bilaterally balanced occlusion in a denture. And what's nice about that is there are certain intracapsular conditions where you don't want them to, how can I say this? You don't want the condyle to see it at all. And really the only way you're going to prevent vertical compression of the condyle is to have bilaterally balanced occlusion. When you adjust your splints, the Gelb styled splints carry, are you trying to maintain bilaterally balanced occlusion or group function in a lateral perspective, or does it matter?
Yeah, I guess I would say the second one, group function in a lateral position.
Yep.
But I actually couldn't tell you what's happening, where the condyle is going. I just would tell you that lots of times with dentures, there are people with dentures that have TMJ issues, and I just use the denture as a guard, and I adjust it basically the Gelb way with group function, and that seems to work for most people. I had one denture patient that had headaches every day for a few years, and he happened to come into me. I couldn't really decide what I wanted to do with him, so I made upper teeth, but on lower I made anterior teeth on a platform. Now, I don't know if I really had to do that, but it worked really well. All of his headaches went away, and he was very happy. So
here's the answer to your question. You were saying what muscles? It's the anterior belly of the temporalis and the inferior belly of the lateral pterygoid when you're in contact in the front.
Yeah.
As opposed to that. This picture here, and I'm sure you've seen it a lot, Carrie. Have you ever seen a case where the interference was on the non-working molar during lateral extrusion? So the patient, let's say the patient is trying to grind to the right, their canine guidance doesn't necessarily disclude their mandible, and they have a premature contact on 18 and 15.
Yeah.
Those are the nasty ones, and they're hard because they're on the other side of the mouth, whereas the patient might have myofascial pain disorder or some sort of muscle problem on the contralateral side or the side that's affected. But in reality, the interference is actually on the other side.
I was going to say, I had this picture at the course the other night, and I kind of skimmed over it. But I think in Sugarloaf, I should spend more time on it.
Yeah, I think
because
this picture and this picture, that's Dawson's textbook in two photos.
yeah.
Yeah.
Now, are there going to be a lot of younger dentists there at Sugarloaf, or will it be just an older bunch of guys that want to ski?
It's always a mix. I'm not part of the, this, the I'm at a loss for words. I don't know who's signed up yet.
How many people are usually there? Like 20 or 50? Or?
No, 12, 15, maybe 20 if it's a good year and it's well advertised. All that matters, Carrie, is Jason and I are going to be there. We can't wait to hear what you have to say.
I won't be there, actually.
Oh,
sorry.
You did say that. Well,
Labani will be there.
We're going to record it for you.
Yeah, it's all good. I'm there in spirit. Don't worry.
Absolutely.
I had a question. I don't want to take too much time, but just a quick thing about Dr. Bryant, is everything coded when you do splints? Is everything coded as like an orthotic? Like there are two codes technically in the CDT. There's like an occlusal guard, which I just assume is glorified bruxing guard, which I think we code for everything. Do you code for an occlusal guard? Do you code for an orthotic splint? I'm trying to find the code.
I think it's 7880, but I don't really know what that stands for.
Yeah, an occlusal or orthotic device. You're right. Okay.
Yeah. The other thing kind of funny is I make fun of people that made splints all the time. And I went to John Droder. He tries to avoid splints. He uses a lot more medication. He uses meloxicam and 20 milligrams of doxycycline, whereas Piper used splints on almost everybody. So after talking about after making fun of people that do splints on everybody, Piper seems to do splints on everybody, unless he can. If you can prove if you can prove to yourself that the joints are pretty healthy, you probably don't need to do a splint. Just do an equilibration or ortho or whatever you think you need to do. But I think that most of the people Piper sees have more damaged joints, so he ends up probably doing more splints for that reason. But I was surprised at how many splints he does. It's like probably 99% of his patients get an occlusal splint, whereas with Droder, it's probably more like 70%.
Doxycycline. Who would have thought?
Yeah, I've tried it before, but I didn't really like the results. And then you've got physicians. I've talked to patients about asking your physician. Well, that's a big mistake because they all say that what if you have a serious infection in the future and you need doxycycline, you might have become resistant to it. So they don't really like to use it for pain as a pain.
But it's a microdosing dose, correct? I think you had 20 milligrams.
Yeah. Much less than for treating, some type of infection.
Yeah.
So I guess, I just had I have a patient that I just thought of that I saw last week. She specifically said that she has a previous orthotic and she wants a new orthotic. At the office, Nick, it's like the patients that come in for an occlusal guard see Chantel, they get scanned, our bite is MIP, they're arbitrarily opened, and it works for those. But when we're gonna code for an orthotic, I don't think I'm gonna send them to Chantel. I'm probably gonna have the patient come into my chair. We're gonna find a bite like a phonetic bite, and we're gonna do, we can still print it or whatever, but I assume if we're gonna do orthotic, the the procedure of getting the bite and all that is important, and all of the follow-ups. Is that fair to say? Like,
Yeah, let's definitely dive into it. But the first thing
Yeah.
that we need is we need a diagnosis and
Yeah.
supporting documentation. So this 17-page thing that I have, and this is not
Yes.
this is the original copy I got from Dr. Chris Spencer. He's oral facial pain doc. He's at LSU now, but he used to be at Florida.
So this will be a good case. I'll have her. She's come, and I'll send you the information of when she's coming in.
Yeah.
For whatever reason, they just changed it to iTeroscan and Chantel's chair and a occlusal guard, but I don't think that's where she's at. I think this patient needs an orthotic, because she used that exact word. She's been made an orthotic before. So I feel like I need to, and she, just my understanding in her bite, she seems like that kind of patient. So we might need to look into that, and it would be worth going through that checklist. Do you do that checklist solely for documentation and all that stuff, or are you hinting at that like medical insurance or something needs to be?
I do it more for me in great part because
Okay.
I think a proper diagnosis requires a high degree of thought of the data, not in the moment of the exam.
Yeah, this is, I think this is a good one to do. I think this is what we need to do. So I don't want to send this patient through Chantel's chair and just go, yeah, let's just spit out an occlusal guard, only to have 6 follow-ups and realize, yeah, we need to go back to that. Basically
Right.
that. Let's get a real diagnosis. Let's get a history. Like, why does she know what an orthotic is? Was that just a term they used, or does she truly need an orthotic? There's also a huge cost difference. I know we just updated the fees.
Is she a dentist? Is Chantel a dentist or a hygienist? Or?
She's an assistant who will capture like the data we need for an occlusal guard, like a bite guard, a night guard. But we're just taking a scan and getting an MIP bite, and then having a computer generated system spit out a night guard. It's for the
apples and oranges. It just happens to be made by the same material. That's it.
Yeah, but I feel like it. My understanding is that the orthotic is going to take a lot more than just go to Chantel, she'll scan you, and here's your night guard.
How about this? The answer is Chantel has nothing to do with TMD treatment.
There you go. That's fair.
Done.
I'm going to move the patient over into my column, because I just was like, oh, let me go check on this patient. I'm going to put her in my column, and I'll put something in there.
I just shared this with you, and this is kind of the workflow.
Okay. I think this will be a good case to not. She's not in pain. Like, I don't think we have to get it, but this could be a really good. She seems like an easygoing woman. She's young. This could be one where I think it could be helpful.
One thing that's important, I'm sure, Carrie, you probably have this built into your workflows, is when we're using an orthotic or a splint to treat TMD, the patient has to know that might not be the treatment that's successful. It might be an equilibration. It might require orthodontics or a full mouth rehabilitation. Carrie, would you agree to that comment, or do you think you can get everybody to the end point with orthotics?
I'm not sure if I heard everything you said, but what I do, I don't charge anything for an orthotic. I charge around $4,000 for a year, up to a year of bite therapy, which includes an orthotic. It includes adjustments. If it breaks, if the dog eats it, I replace it. And if it doesn't work, I try to switch it over. So there's no hidden costs unless they lose it. And then I charge around, I think it's $900 to redo it. But
that's a great.
Can you repeat your question? Maybe I'll get it.
Before I rephrase that, I think that's a beautiful framework, that you're not charging the patient for a piece of plastic. You're charging them for a therapeutic process over a defined period of time. That's awesome.
Yeah, because they can get an orthotic for $50. So if
Right.
if they compare $50 with $4,000, they're going to tell me to shove it.
Right.
Okay.
So my question was, do you ever educate the patient on the fact that the orthotic might not be the therapeutic device, that it might involve something above the $4,000 that they spent, such as orthodontics or a prosthetic rehab,
Yeah, or oral surgery.
oral surgery? Yeah, I didn't actually put that here.
Can a splint, if the patient is fine tolerating a splint, can that be the final?
Yes.
Can that solve 99% of?
Yeah, if you had come to the first 20 minutes the other night, I showed pictures of before and after MRIs of joints that had broken down, and then joints after 1 year of bite therapy with an orthotic. And you can clearly see that the bone filled in. They could open or out of pain. And at that point, once you've got the foundation stable, you can go on to whatever you think they need, whether it's orthodontics or an equilibration. And sometimes, I'm going to say 40% of the time, people choose to do nothing. They just want to use an orthotic for the rest of their lives. And even when I tell them that they might lose it or it might break, they still don't want to go further with the equilibration or the orthodontics. So I leave it up to them. But yeah, and I also tell them right in the very beginning, I said this works over 90% of the time, which is a nice way of saying that sometimes it doesn't work.
Yeah.
If it doesn't work, then I'm inclined to send you to an oral surgeon, either in Baltimore, Maryland, or St. Petersburg, Florida, because the guys in Maine don't do the type of surgery that I feel is more predictable.
Okay.
You know, the guys here in Maine will open a joint, clean it out, and it feels great for 6 months. But if they haven't taken care of the what's really going on in the joint or the bite or whatever it is, then usually that pain will come back.
Yeah, maybe the next time we meet, we can go over arthrocentesis and what that is and what it's doing. Let's do that. But I'm just going to put a cap on this presentation. I'm going to hit stop